Welcome.
Hello.
Hello. Thank you so much for being here. My name is Maria Coutant-Skinner. I am the Rotary Chair of this Addiction Task Force.
And I am Heidi Zachra, the Lions co-chair of the task force. Thanks, Greg.
Whoa. The Lions got the applause.
It's all for me.
Very nice. That's right. That's right. So we'd very much like to welcome you. Thank you so much to our hosts, the American School for the Deaf. And thank you to all of you for being here. And we're so pleased about tonight's topic. Heidi and I just wanted to take about 2 minutes to give you a little history, the origin story of this group. And so you can kind of take that back and hopefully help to amplify our work and our message. In the 2017-2018 year, there was a group of Rotarians under Dave Mang's leadership that looked at the impact of the opioid epidemic originally and thought, as service club members, we have a unique opportunity to be able to mobilize a whole lot of volunteers across an entire district. And we took some time to really assess where those issues are, build capacity, and then refine what our goals were. And in doing so, we were able to get connected up with the Lions, who just naturally was a wonderful fit. And what we came up with was to look at addiction in home, workplace, and community, and target our efforts in those three areas, and came up with some ways of doing that. And so Heidi's going to talk to you a little bit about the home component.
So the first phase that we decided on was to get unused medications out of the home, because that really, we felt, is one of the bigger issues. So we wanted to educate everyone on the drug take-back boxes, having them in your community, the drug take-back days, and then the other thing we had our clubs stand behind were the Deterra pouches, which are the drug deactivation pouches. You put the drugs in, put some water in, shake it up, and it deactivates the drugs. And so now we have the Lions clubs and Rotarian clubs in the state of Connecticut, if they choose to, purchasing these pouches and making them available to different pharmacies around the state, so that the people who are getting an opioid will have the option of having this pouch to get rid of unused medications. And then we moved on to phase 2, Maria.
So tonight we're launching this phase, which is looking at addiction in the workplace. And in my work as a clinical social worker and director of a behavioral health organization in Torrington, I came to know Monty Frank. And through his work, which he'll tell you about in a few minutes, of organizing attorneys and looking at employee law, employer law, and how we can effectively intervene with addiction in the workplace, I thought, oh my gosh, this would be a wonderful fit. So again, kind of networking, building community, understanding how we can leverage resources to really look at solutions for this issue. Went to Monty and he said, I'm in. Let me know what I can do. So we have this extraordinary high caliber group willing to do this presentation. So happy that you guys are here. We also are really fortunate to be able to have a television station from out of West Hartford recording this to be able to share this afterwards through YouTube. So we'll make sure a link is available to all of you. And there'll be a question and answer portion of tonight. When that time comes, we'll be able to bring a microphone out to you to ask the questions, and you can direct that to any of our panelists. But without any further ado, I'm really pleased to introduce you to my friend, Monty Frank.
Thank you, Maria. Thank you, Heidi. And thank you for your leadership on this critical issue that is impacting all of our communities, whether you live in an urban environment or out in the suburbs. The opioid crisis doesn't discriminate, it doesn't know any bounds, it affects the rich, the poor, and it affects all of the workplaces that we go to. And so, how did I get involved in this? I'm actually lucky in that so far, I have not experienced any loss in my life due to the opioid crisis. directly. I've had friends who have kids who have gone through it. And, you know, I looked at this back in 16 and 17 when I was president of the Connecticut Bar Association as a ticking time bomb. If it hadn't exploded already, it certainly was going to explode soon. And it was just a matter of time before someone knocked on my door and said, okay, now you've got a problem in your family, deal with it. So when I was president of the bar, I looked around and I tried to determine, you know, what is it that lawyers are doing to try to reduce the impact of the opioid crisis. And I found out that we weren't doing much. And I looked at other bar associations from other states, and they weren't doing anything either. So I got together with some of my colleagues, and we formed the Connecticut Bar Association Opioid Task Force, which was a group of lawyers, judges, prosecutors, defense attorneys, employment lawyers, healthcare lawyers, and then we also invited some clinical people so that we could educate ourselves as to, you know, what this disease was all about. And Dr. Tobin enthusiastically joined the task force and provided his expertise. And I can't tell you how much I learned from him as to what is the science behind opioid addiction. And because once you understand the medicine behind it, you begin to realize pretty quickly that we're not talking about junkies. We're not talking about people who are bad. It's like any other disease that people suffer from. And he'll run you through that, and then and that will set the context for the discussion on what can we do in the workplace. And I learned a lot about that when I ran for lieutenant governor. I was Oz Griebel's running mate. We ran a open, honest campaign based on policy. And in that capacity, I spent a lot of time with Maria up at the McCall Center, meeting with her treatment providers. We had roundtables where we actually brought in individuals who are willing to talk about their opioid abuse disorder and ways that they were combating it and getting themselves into treatment so that they could go back to a productive lifestyle and hopefully integrate into the workplace. But what I discovered through my journey around the state is we have amazing people on the front lines doing work in the streets, in neighborhoods, in combating the opioid crisis. We have lawmakers who are engaged, who are seeking federal dollars, who are going to the legislature to get money for various programs, who are working with the bar and others, or developing new laws so that we can be as progressive as possible in order to have the laws in place so that we can combat the opioid crisis. But what I discovered was that there was a big gaping hole. And that hole is the workforce. And if you think about it, who better than an employer to maybe discover that one of their employees is, you know, had a car accident and was prescribed Vicodin, and maybe the pain is still there, but the Vicodin has gone to different uses, and that person may have just been more susceptible to, and Dr. Tobin will explain how the brain functions, and all of a sudden that person who had a back injury is now addicted and is showing up late to work, or is missing days, or is falling asleep at their desk. And so if we can educate the workplace as to what how to find those things and what the laws are, and to help an employee get into an employment assistance program and eventually get into treatment, wouldn't that be a wonderful thing, that we could detect a problem before it became too late? And then conversely, on the back end, when people are coming out of treatment, and often their lives have been ruined. They've lost their job, they may have lost their housing, they're struggling to make ends meet. If we can get them that job so that they can go back to being a productive member of society, they can start paying their bills, they can pay their rent, they can demonstrate to their family that they have some worth. And that will hopefully help them from relapsing and provide that self-confidence that is so necessary as treatment continues. So if we could educate the workplace on, how do you deal with within the law and otherwise with someone who's come back into the workforce? What are the different laws that apply? How do you engage in an interactive process to make sure that if someone is undergoing a medicine-assisted treatment program, that they're provided with an accommodation to go out and go to the methadone lab? Or how do you deal with someone who tests positive for Suboxone, which is an opioid, but it's prescribed by a medical provider in order to help somebody to not have those severe withdrawal symptoms. So those are the things that Marie and I talked about, and as we discussed it more, we were fortunate that Rotarians and Lions were interested in having this program because it allows us to go out and educate the workforce on what we do. So with that background, that overview, I just want to introduce some of my friends and colleagues who are here with me today. Dr. Tobin is an associate professor of medicine at Yale University, where he serves as a clinician, educator, and medical director of the Yale Primary Care Residency Program. Dr. Tobin has been a warrior in combating opioid abuse disorders throughout the state. He never says no to a panel, to a program, to a speaking engagement. And I'm proud to call Dr. Tobin my friend and colleague. Megan Carinanti is one of my colleagues at Pullman & Comley. She works hard with her clients and focuses on business to minimize the cost with protracted litigation, represents a wide variety of clients from big Fortune 500 companies to mom and pops in business, employment, and construction disputes. And she regularly appears before the Connecticut Commission on Human Rights and Opportunity and other state and federal agencies, admitted to practice in Massachusetts, New York, and Connecticut, and regularly represents clients in these jurisdictions. And to her right is Robert Hinton, another one of my colleagues at Pullman & Comley, extensive experience in all phases of commercial and complex litigation and employment law counseling, is in our employment practice as well as with Megan, and significantly took a leadership role in the Connecticut Bar Foundation's Opioid Summit, which again was designed to bring people together to have discussions across many disciplines in order to work together to combat the opioid crisis. Bob's a graduate of the United States Military Academy at West Point, and before beginning his legal career, he served more than 8 years on active duty in the United States Army. So we've got an incredible panel. And so what we'll do first is I'll turn it over to Dr. Tobin on the medical background, and then we'll talk about drug testing, the FMLA, and the ADA, and explain to you how all that works, give you a couple hypotheticals, and then open it up to your questions. Dr. Tobin.
Perfect. Thanks. All right. It's a real pleasure to join you guys tonight. I am first and foremost a primary care doctor. I take care of my own patients for everything from hypertension to opioid use disorder. But I also do a lot of teaching, and over the course of many years, pain and addiction have been very prominent in what we've had to work with as teachers and as learners. And over the course of time, I've really discovered that as a clinician, there's only so much I can do without reaching out beyond medicine and engaging with teams. And that means teams of educators, but also law enforcement and policymakers and attorneys and advocates of all kinds, including patients who lead a lot of these discussions. So in that context, I'll do my very best to give you a background and overview of this issue, sort of a mini med school degree in 15 to 20 minutes, so it might seem a little intense. And I think a good place to start would be to just talk about terminology. The words we use matter a lot. They contribute to stigma, and they contribute to misunderstandings of the problem. So let's just go through some commonly used terms. So first, we can't talk about addiction without talking about pain. These things are often connected, and oftentimes an opioid use disorder will start from somebody who's exposed to an opioid for pain. So acute pain usually is something that we think of after an injury, but it could be also an illness. And this actually is not a bad thing. We don't want people suffering from pain, but acute pain can be life-saving. If you happen to, put your hand on a grill thinking it's off, and it turns out it's on and going to burn you, it's a really good thing to feel pain, so you can pull your hand away. So pain is protective in some ways. Chronic pain's different. So chronic pain in medicine we usually define as pain that's lasted beyond 3 months or after the time it took for the underlying injury or illness to heal. And as far as I know, that has no life-saving benefit whatsoever. It is a problem in and of itself and becomes a source of great suffering for a lot of people. Opioids is the term you'll hear me use most. And that refers to both opiates, which are the naturally occurring opioids or derivatives of morphine and codeine, and the synthetic opioids like fentanyl, for example, that we use in medicine or are used illicitly. Narcotics is a term that you might be more familiar with. Now, that's a term I try very hard to stay away from. For a few reasons. First, actually, it's not specific from a medical point of view. So cocaine is actually considered a narcotic by the Controlled Substance Act, even though it works in the body nothing at all, like something like morphine. And there's a lot of stigma that's associated with the word narcotic. And really, it's turned into more of a law enforcement term. So in your fields, I suspect you will continue to hear this word, but I try to work hard to avoid that terminology. Misuse, dependence, and addiction. So these are not the same, and I think it's important to define these two. So misuse really refers to using a medication differently than it's prescribed. It could be taken for a different reason, used in a different way, used at a different dose, any of those things. And that may or may not be something that is representative of addiction. Physical dependence is frequently misunderstood as addiction, but they're definitely not the same, and this is an important concept. So physical dependence is your body's normal adaptation to repeated exposure to a substance, in this case, an opioid. And so that might mean that you need more of the exposure of the same substance to have the same effect, tolerance, or that when you're used to it and then it's taken away, you go into withdrawal and you get sick. Somebody who is on chronic opioid therapy for pain and uses it as prescribed without any addiction will still have tolerance and withdrawal in many cases. That does not mean that they're addicted. That's just their body doing what the body does. What addiction is really a brain disease. And so this is where you have these cravings to use the drug or the substance and compulsive behaviors to get it, really characterized by a loss of control. So even in the setting of harm, you can't control yourself and you're still doing these behaviors. Often you'll see these things happen together, but they're not the same. So just to take a little deeper dive into the history of opioid use, our relationship with opioids long predates modern medicine. As early as 3400 BC, there's evidence that the opium poppy was being used in Mesopotamia by the Sumerians, actually to have joy as a euphoric agent. So way, way, way back, it was still being used for this purpose. Fast forward to the 1800s, and actually we were giving opium and morphine and cocaine to children, and it was advertised that way to help with teething pain and other colic and other kinds of childhood problems. I think there was very clearly misunderstanding that back then that was not a good thing. In the 1860s, during the Civil War, Morphine was a very important battlefield drug, and it was used to help treat soldiers who suffered injury on the field. As you might guess, a number of soldiers went on to develop morphine addiction. So, lo and behold, 1898, Bayer introduces heroin to treat morphine addiction. It's quite ironic, isn't it? But it was actually introduced therapeutically for that purpose. And so you can see that over many, many years, hundreds of years, we've really had this kind of strange relationship with opioids. Now, today we have a more modern understanding of these medicines and these substances and how they affect the body. And I'll start with this, what looks like a complicated thing, but I'll try to break it down pretty simply. This is a representation of pain and the pain processing in your body. And on a very simple level, oftentimes there's some stimulus in the outside world that causes pain, and it activates the nociceptor, the pain receptor in the outside of your body. And then you've got this pain signal that gets transmitted to the spinal cord. The spinal cord then needs to process it, and it sends a signal up to the brain. The brain has two jobs. One is to process it further, but also to understand what's going on and to sort of interpret the signal. And then the brain will send a signal back down the spinal cord to the rest of the body, saying, I get it, I understand what's going on here. And usually that's an inhibitory signal, so that it kind of suppresses pain heading up back to the brain. This is critical to understand because different parts of the pain pathway are affected by different substances. Opioids actually affects all three of these parts, the transmission from the outside world to the spinal cord to brain, and brain back down to the rest of the body. So it actually makes sense that opioids should be useful and effective for treating pain. And in fact, for acute pain, they are. It's a lot less clear when it comes to chronic pain, and we'll talk about that in a few minutes. But as I'll get to a little later, really importantly, some of these things that happen in the brain are the exact same pathways that are affected and in a bad way with addiction. And as you'll see, these two things often will go together. But let's start with pain again, because pain is just as much of a problem as addiction in many ways. 100 million Americans are thought to suffer from chronic pain. That's about 1 in 3 Americans in the US. 25 million from daily pain, 40 million with severe chronic pain. And this costs a fortune, so $600 billion a year in lost wages, reduced productivity, and treatment costs. So it's an extremely expensive thing. And moderate to severe pain is also one of the most common things that we see in primary care. And as a primary care doctor myself, I can tell you this reflects what I see in my own practice. It's the number one complaint that people come in with. Now, in the 1990s, we really started to have a better understanding of some of how impactful pain is on people. And unfortunately, we started focusing on it in a way that turned out to be counterproductive in many ways. So in 1996, and this is an important milestone, the American Pain Society promoted this concept of pain as a fifth vital sign. Now, this is well intended, and the idea was to say, well, people are suffering, we should screen more effectively, and we should treat people more effectively for pain. Pain's not a vital sign, it's not your pulse, it's not your blood pressure, there's no objective test that I have to determine if you're in pain. The only thing I have is your self-report, but that's how it was presented to help people kind of remember to ask about it. Well, this concept was embraced by the VA system and actually became a mandate in the Veterans Health Administration in the year 2000. And then in the couple of years that followed, linking pain screening and treatment to accreditation and also to reimbursement to hospitals. And when you start to link money with pain screening, you can kind of get a sense that things will get out of hand pretty quickly, right? If you get reports that you're not screening adequately and treating patients' pain adequately, and then you don't get reimbursement to your hospital, well, guess what? There's a lot of pressure to be more aggressive with that. So that was one of the contributing factors to the overprescribing of opioids in the 1990s. There were many, many other things. So, under a lot of this pressure, it's understandable why doctors would turn to a substance that should be helpful for pain, opioids, and try to use it to treat people. Unfortunately, we were never trained how to do it. So in 2011, only 5 of the 133 medical schools in the whole country had any mandatory coursework on treating pain. So that means that the majority of doctors in practice graduated without ever really learning how to do this safely. And that includes many of the doctors who you probably see. And then there's this theory, well, that doesn't really matter because I'm a primary care doctor. I can just ask for help. And so maybe I'll refer my patient to a pain specialist. But unfortunately, there's only 4 board-certified pain specialists for every 100,000 people in America with chronic pain. In our state, for Medicaid, there's only 12 pain specialists for every person on Medicaid in the entire state of Connecticut who are still accepting new patients. So it's a fallacy. This is not actually a resource that most people can tap into. And many of the pain specialists only do procedures, or they actually don't do the kind of comprehensive assessment that I think we would hope that they would do. And then there's limited coverage by insurance companies to treat pain with things other than opioids. Some of the non-pharmacologic treatments like yoga and massage and cognitive behavioral therapy and acupuncture, some of these things are really hard to get covered. It's just easier actually to get coverage for a pill. And when you put all these things together, unfortunately, it leads to overprescribing and unsafe prescribing. And then pharma plays a very important role in this too. You might remember going back to 2007, the Purdue Pharma, makers of OxyContin, agreed to a $600+ million settlement for inaccurately representing the nature of the addictive potential of their drug OxyContin. And much more recently, last year, Insys Pharmaceuticals, this was a company that was found guilty of racketeering, bribing physicians to prescribe their fentanyl-based product. So pharma, in sometimes very subtle ways and sometimes very overt ways, has been part of the problem too. Pharma has also, in some ways, been really interested in being partners to help with solutions, but over the course of time, they've been a contributing factor. Now, in America, we use a lot of opioids. We use more opioids than the rest of the world. 99% of the world's hydrocodone is prescribed and used in America. There were 236 million prescriptions for opioids in 2016. That's enough for every adult in America to have their own bottle of pills. That is a lot of supply. And since the 1990s, these numbers really have quadrupled. The graph, which I don't know if you can see real clearly, on the bottom is the United States, and it just shows on a, if you were basically standardize the dose of all the different opioids, how much more we use than most of the rest of the world. So, probably not surprising, as we've used more and more opioids, more and more people have overdosed and died. And this graph here over here, the green is the sales or filling of opioid prescriptions at pharmacies, and the orange line are deaths, overdose deaths related to opioid use. And the thing to point out is they rise in parallel. So the more that's being prescribed, the more that's available, the more people are dying. And many of the deaths aren't to the person who was prescribed the medicine, right? Because of diversion. So it's gotten into the medicine cabinet by the kids or by the babysitter who sells it. And so it's the collateral damage. It's not just the person, him or herself, that actually got the prescription. And 130 Americans die every day from unintentional overdose, which includes heroin. Now, what about in Connecticut? So in 2018, 1.96 million prescriptions written for opioids, sort of similar in proportion to the national data. Now there's good news here. The good news is that the number of opioid prescriptions written in our state is falling. It actually was less in 2018 than 2017 and 2016. And if you look at it compared to the rest of the country, actually there are fewer opioid prescriptions for every 100 people in Connecticut now than there are in most of the rest of the United States. That sounds like really good news. However, the bad news is the number of overdose deaths continues to go up. So that's a little counterintuitive, right? Why would that be happening with all these connections I told you about? Well, think about it. So if it's more and more difficult to get an opioid in a legitimate, safe, prescription-based way because now doctors are fearful to prescribe or because of restrictive policies, then what happens? People who need the medicine because of pain or who have addiction turn to other sources, right? They get it from the street where it might actually now be adulterated with fentanyl and it's a lot less safe, it's a lot less controlled, and they're more likely to die. So it's this squeezing of the balloon phenomenon, right? And when I teach the trainees at Yale about this, or I talk nationally about this for the FDA, I try to promote rational prescribing. It's not overuse and underuse, it's like rational evidence-based use, which is really hard to teach, but really, really important. The overdose deaths in Connecticut, so in 2018, 1,017 accidental drug deaths, nearly 4 times more from overdose than from car accidents, and 948 involved an opioid. Many involved fentanyl. Overdose deaths in 2019, we don't have final data yet, but 1,088 accidental drug deaths is the projected number, and it's projected to have been the worst year ever. So this is a very significant and serious problem in our state. Now, when you think of overdose risk with opioids, there are some factors that will raise that risk and make it predictably more dangerous. That includes things like higher doses and higher potency of the substance. When it's used with other substances like a benzodiazepine, these sedatives, you put a sedative together with an opioid analgesic, it's more dangerous than either one used by themselves. When it's mixed with alcohol, that definitely raises the risk. And then when it's injected or adulterated, that definitely raises concern. Now, somebody who's already suffered a prior non-fatal overdose, they've overdosed, they survived, is also at much higher risk for having an overdose again. And so that's a target at-risk population. When tolerance is low, that's a time of concern. So for example, let's say somebody with an opioid use disorder, opioid addiction, is in prison, and they're not treated while they're there with a medication for their opioid addiction. Well, they get out of prison, and even though their body is no longer tolerant to the medication, their addiction is still there. And they may still have cravings to use substances, but they're used to a certain dose or a certain amount that they can't tolerate anymore. And so even with the recurrence of low dose of use, they're much more likely to die. And then people with sleep breathing problems, like sleep apnea, are also at much higher risk. So let's turn to misuse and addiction and just make sure we understand what we're talking about. I mentioned misuse as using an opioid differently than prescribed. That's estimated to be about 25% of people have this as something that they experience. Now, addiction is about 10% of everybody who's exposed to an opioid will develop an addiction disorder. So that means that the person who is prescribed opioids for their chronic pain and uses it exactly as prescribed, about 1 in 10 times will go on to develop opioid addiction. So it's terribly common. 9 of those people won't go on to develop it. It can be really hard to predict who's going to have this problem and who won't. A lot of it is genetic predispositions, and family history is definitely an important consideration, but it's very prevalent. Now, in the 1960s, 8 out of every 10 heroin users entering treatment reported that their first use was heroin. They started with illicit medications. In the 2000s, 75% reported that their first opioid use was a prescription, and then they turned to street use later on. So even though I told you that overly restrictive prescribing is part of the problem, and it is, it's still true that we overprescribe and overuse opioids, and the medical community needs to continue its efforts to use it rationally, less often, and carefully. So this is really important now as we talk about the rest of our time together. And that's this concept of hijacking the brain. So the neurotransmitter dopamine is the chemical in the brain that really helps reinforce behaviors as the pleasure neurotransmitter. And many of the same pathways in the brain that are affected by opioids when they treat pain are also affected in addiction. And so they lead to this dopamine dysregulation. And so you stimulate the dopamine pathways, and it makes you want to do more and more of it, right? Now, that's not always a bad thing. Our bodies were designed this way because it's kept us alive, helps us, for example, eat, helps us have sex so that we can keep our species going. These are behaviors that keep us and our species going. But the opioids stimulate the same pathways, and we know that having cocaine or morphine will raise the dopamine levels from 10 to 100-fold in comparison to eating or having sex. So you can see how this would be very reinforcing for people who are susceptible to it. And over time, what happens is your brain adapts in a way that's counterproductive. So the dopamine signaling pathways become less responsive. And so that means that it's harder and harder to feel pleasure at all. And people who suffer from opioid use disorder or opioid addiction, they'll often say that, I don't ever feel pleasure. I'm just trying to not feel sick. And I'll get to that a little bit more in a moment. But it leads to these intense cravings just to feel normal because of some of the changes that occur in your brain with chronic opioid exposure. Now, when you think of opioid use disorder, a lot of times somebody who starts by using these medications or substances illicitly to get high, for euphoria, they'll start in a normal state, they'll use a substance, they'll have euphoria, and then that wears off and they kind of go back to normal. And then over time, each time they use the substance, that euphoria, they can't quite get to the same level because your body adapts, you get tolerance to it. And then pretty soon, you can't get there at all. This is completely blunted. And so what happens is those folks use these substances just so that they don't feel ill. Because when they're not using it, they go into withdrawal and they get sick. And they feel like they're dying. So essentially, somebody who's suffering from addiction and is not being treated often is just motivated by being sick all the time, which is a really terrible way to live. So in the medical field, when we talk about treating people with opioid use disorder, in addition to all the supportive counseling and so forth, we often use the gold standard medications, methadone and buprenorphine, which is mixed with naloxone to be Suboxone. That's the term that Monty used before. And the way these medications work is they basically kind of even out the levels in your brain and in your body so that you don't have euphoria, you don't have the high, and you don't go into withdrawal. You stay in a state that lets you kind of be normal, lets you just function. And by blocking these like wild highs and lows, it really lets somebody get their life back together again. And that's the way it's intended to work. There's a lot of similarities between the two. There are many, many differences. One very important difference is that Suboxone and buprenorphine can be prescribed by your primary care doctor who's got training in the office. You don't need any sort of, you don't have to take off from work all the time to go to an opioid drug treatment center. You can get, once you're stable, a 30-day supply of buprenorphine and just through your doc. And you go to the waiting room and it's somebody next to you has a cold. There's no stigma there. So we're really working hard to try to encourage physicians and nurse practitioners and PAs to be trained to do this. It's a significant investment in time, but it just makes the treatment so much easier. And there are many, many advantages to doing this. So the data shows less illicit substance use, lower rates of viral hepatitis and HIV, a definite decrease in the risk of overdose death, reduced injection drug complications like endocarditis, heart valve infections, and skin infections. There's much more engagement in behavioral activities and employment, as we're talking about today. There's a decreased risk of dangerous and risky behaviors like stealing and crime. There's a reduced risk of legal consequences. And you have more available time to actually just be a person, have a family, have a life, and kind of be an engaged citizen. And importantly, it is not just trading one addiction for another. I hear people say this, because they don't understand it. Remember, addiction is loss of control despite evidence of harm. This is a treatment that helps you regain control and keeps you away from harm. It is the opposite of addiction. They're definitely not the same. So you are now all experts in pain, opioids, and addiction, and I hope that gives you enough of a background and a foundation to kind of understand some of the rest of what we're talking about today. It's really been my pleasure talking to you. Thank you so much.
Hi, everyone. Can everyone hear me? Yes. Okay. As Monty introduced me, I'm Megan Carnante. I am an employment counselor and litigator. And I became interested in this issue because a lot of the employers that I work with regularly were encountering some of these issues and not really knowing what to do, how to support their employees, but still protect themselves. And so I am one of the people in the firm who really focuses on the drug testing aspect, and then also on trying to come up with solutions for employers to make sure that they have good policies and that they can also enter into agreements with employees who are struggling with various types of addictions, both alcohol, drug addictions, to try and help keep them involved with the company, because as employers, you invest a lot of time and energy in an employee, and you want to try and help support them through whatever they're dealing with, just like in a variety of different ways. Addiction can be something very similar to any type of challenge that an employee is facing. So first and foremost, I just want to go through some of the drug testing laws. There are, in any type of legal situation, you've got federal law, you have state law, and then sometimes you have local law. Today I'm just going to focus on federal law and state law. And generally the test that I like to tell people to help remember it is, if there's two different laws that apply, both federal and state, you're going to apply the one that is more favorable to the employee. So if there's greater protections to the employee under state, for example, you're going to make sure that you comply with that. In terms of federal law, there's no federal statute that generally regulates how employers conduct their drug testing. There are certain industries, though, where there are requirements that employers do conduct drug testing, and those are obviously safety-sensitive type positions. So, for example, the Department of Transportation has certain requirements and provides for different types of testing that can be done, which is more comprehensive and allows for greater testing in a greater and wider variety of circumstances than just your typical employer who is not having people out there operating motor vehicles. So under DOT regulations, you can drug test before employment, during employment based on reasonable suspicion, on a random basis, when an employee returns after a positive test, on a follow-up basis after return to duty, and post-accident. So these are all a wide variety of different ways that you can drug test under DOT regulations. There used to be a lot more people that would drug test in all sorts of industries like this, but you can't really do that anymore. So that's a misconception that I come across. There's also a Drug-Free Workplace Act, which applies to federal contractors. I'm not going to get into that much now, other than to just make you all aware that someone who is a federal contractor, therefore they receive federal money, there are certain requirements that they must comply with. It doesn't require drug testing, but there are certain reporting requirements and the like. Connecticut also has its own state-specific drug testing law. That applies in the private context, so not public employers, but any type of individual, corporation, or partnership other than a state or subdivision of the state. That allows for pre-employment urinalysis testing, but there's certain preconditions on if you're going to do this type of testing. Generally, the labs know what the requirements are and follow that, but there has to be a consent that's signed by the applicant. This is something that I see a lot with employers, is they're doing drug testing and they're using forms from ADP or some other nationwide service, and they're not looking to see if it complies with Connecticut's requirements, and sometimes I have found that they do not. And so an employer could be actually violating the Connecticut statute when they have no idea, just because they're relying on a national form. There's also requirements with regard to the methodology that's used, and that's to try and make sure that obviously things are as accurate as possible, and you need to give a positive drug result to a prospective employee so they're aware of it. It's very important if you are doing drug testing that you're maintaining the confidentiality of those results, that you're treating them like any type of medical documentation. We were talking before about prospective employees. Now, what happens if you want to test your current employees? That's, after they're employed. You're a lot more limited in your rights to do that. You can always drug test a current employee if you have a reasonable suspicion that they are under the influence of drugs or alcohol while they're at work. That's difficult to tell sometimes, and that's why we always recommend that you have clear policies, that you train your managers and your supervisors in signs and symptoms to look out for. And it's extremely important when you are an employer to make sure that no one is under the influence at work if it is affecting their safety or another employee's safety. So obviously, the safety risks and concerns are going to differ widely depending on what the employee's job responsibilities include. If someone's operating a forklift, they may be a lot more likely to hurt themselves or someone else or machinery than someone who's sitting behind a desk. You can also drug test a current employee if a random test is authorized under the statute. As I mentioned, similar to the federal industries, if the Connecticut Department of Labor has approved testing of a safety-sensitive position, for example, forklift driving would be one of those examples. That's where you could do random testing. Also, you can random test somebody who has a CDL license, and we're going to get into that with a hypothetical later. Lastly, you can do a test of a current employee if they are part of an employee assistance program in which the employee is voluntarily participating. And we're going to talk about that in a little while as well. But I think this is a good mechanism that allows employers who want to try and work with employees who are struggling to try and support them and focus, as we've discussed, about trying to change the framework and trying to see this as more of a support system and a rehabilitative process as opposed to a punitive one. Drug testing for public employers is going to be a little bit different. As I said, the Connecticut drug testing statute doesn't apply to public employers, but there may be collective bargaining agreements that apply and federal, state, or local laws. I'm going to turn it over now to Bob Hinton.
Hi, I'm going to talk briefly about the Family and Medical Leave Act, commonly known as FMLA. And let me start by saying FMLA is a big subject area. We could actually give a whole day seminar on FMLA. So I want to give you an overview and kind of limit my remarks as to how it would impact on the, with what the subject matter of today being addiction. So FMLA was passed in 1993, and this is really the crux of the act. The crux is that it gives employers the ability to give 12 weeks of unpaid leave per 12-month period to your covered employees. Are most people familiar with the FMLA? And you might also know that there's another act, and Megan talked about this, called the Connecticut FMLA. So there's both the federal and the state act. And you may have seen the news within the past year, Connecticut has now passed paid FMLA, which is going to be quite interesting to see how that comes to fruition. And then, again, that's a whole nother seminar. But the most important thing is it really gives you the ability to care for your family member. So what is a covered entity? Who does it apply to? It applies to private employers. You have to have 50 or more employees, and it doesn't apply to municipalities or boards of education, but that's a federal act. But for the employee to be eligible, the rule is that he or she has to be employed for no less than 1 year and have worked at least 1,250 hours during that preceding 12 months. So it's on a rolling basis. It's not from January to February. It's the preceding 12 months. If the employees reach that 12-month period and he's worked that number of hours, then he's eligible for FMLA leave. So people take, eligible employees take FMLA to care for parents, children, husbands and wives. There's also service member FMLA leave. But that's the whole gist of the act. It's giving someone time off from work to care for a family member. So one of the most important terms in FMLA is this term serious health condition. That's what really triggers the act. And a serious health condition is defined as an illness, injury, impairment, or physical or mental condition that involves really two things. You have to have some inpatient care in a hospital or residential medical facility, or continuing treatment by a healthcare provider. So there's a lot of case law and cases that grapple with this issue of what is a serious health condition. It's interesting that nothing in the statute says that going to a rehab center and receiving the rehabilitation services amounts to a serious health condition. But there is a regulation that addresses this issue head on, and that's this CFR right here. And it says FMLA leave may only be taken for treatment for substance abuse by a healthcare provider or by a provider of healthcare services on referral by a healthcare provider. On the other hand, absence because of an employee's use of the substance rather than treatment does not qualify for FMLA. So let's walk through this a little bit. So I've been doing this for counseling employers for over 20 years. And at the beginning of my career, the common question that I got from employers about FMLA leave and about, especially when it involved substance abuse, what do you think the common question was? Just as a guess. Can I fire them? Right? That's what employers want to know. You're my lawyer. I'm calling you. Can I fire this person without being sued and am I on firm ground? That's the reality of it. Now I have to tell you that field has changed. That's not the dominant question. It's certainly all employers want to know their rights and where they are. But I think it's a good thing for our society that is not, at least for my practice, that's not the main question that employers are asking. So the FMLA provides protection for the employee undergoing substance abuse. If a family member's getting treatment, it works for that as well. But the key thing to remember is that it doesn't provide protection for employees who are absent or using drugs illegally. So a couple of cases, let me just point out, for example. There's a great case from the 7th Circuit where an employee was going through rehab, and the rehab was supposed to start August 8th. And this was for alcoholism. And the employee actually did not start the rehab. He started the rehab August 12th and was just absent and went on a binge until the 12th. And he finally reported to the treatment and went through the treatment. But that absence period where the employee was supposed to be in the treatment was enough for the employer to say, this puts you over your limit. They had a number of points for each day you're absent, and they terminated her, even though the employer went through, eventually received the treatment. And that was affirmed by an appellate court. And I cite that case because it goes to show you how these issues are really hard, in my opinion, because while the employer is receiving the treatment, while they're in rehab, that's FMLA. Where it gets gray is what happens when the employee has goes back and has an issue or misses some other time or falls off the wagon. Those are really tough issues, I think, for employers, and it's often not a legal issue. I can give you I can tell you what the law says and what you can and you can't do, but I think it's bigger than the law. It's really what Monty was saying at the beginning. It's how are we going to get people back functioning at the right level, being productive members of our society. So that's FMLA, and now Monty's going to talk about the ADA.
Thank you, Bob. All right, so we've heard from Dr. Tobin, educated you about the medicine and potential stigmas, what causes somebody to have an opioid abuse disorder. And then we heard from Megan, who talked about drug testing and what are your rights as an employer to conduct drug testing. And then we heard from Bob, and now I'm going to talk about the ADA. But the one common thing that between all of our presentations that I want to convey to you as employers is that if you have a zero tolerance policy, you will end up in the courtroom. So the notion that you're going to do a drug test, and if somebody tests positive, without asking any questions or engaging in any sort of interactive process, and you fire that employee, you will be sued. Maybe not the first time, maybe not the second time, but if that employee finds a lawyer who is educated on these issues, you may have violated the law and you may have exposed your company to significant liability. So the liability is one part of it. But the second part of it that I think we're all trying to convey, and the reason why we're doing this workshop, is putting the law aside. Who are we as employers? What sort of change can we make as employers to help our employees get past this illness and come back to work and become productive members of our workforce? And I'm not just saying that because I believe it. If you look around the country, there are actually employers out there who advertise that they are friendly to those undergoing treatment. New Hampshire passed a law that encourages employers to bring back employees who are undergoing treatment. And why is that? I'm sure Maria can attest to it, that when somebody has gone through treatment and they realize that they have, that their life was almost ruined and they could have died, and you give that person a job and you give them the ability to rebuild their self-esteem and provide for their family and be a good parent or a good husband or a good wife, they're unbelievably grateful and they become incredibly productive members of your workforce. So that's where the FMLA comes in, as Bob described, and that's also where the American with Disabilities Act comes in. So when you look at the ADA, you see it in many other contexts, but it also applies to addiction. And what it does is it prohibits employers from discriminating against qualified individuals with disabilities, as well as against individuals erroneously regarded as disabled. So if you perceive somebody as disabled and you treat them accordingly, whether they are or not, you could be violating the law. And it applies to any employer of at least 15 persons. And recovering alcoholics and recovering drug users are protected from discrimination under the ADA, provided they are not drinking, intoxicated, or under the influence of drugs on the job. So if you have that zero tolerance policy and somebody tests positive and you fire that person without asking any questions, you could be violating the law. So for example, Dr. Tobin described somebody who may be going to a methadone clinic to treat their opioid abuse disorder. If they are tested, because methadone is an opioid, as is Suboxone, they may test positive. And there are questions as to what sort of test will actually pick that up, because the testing is difficult when you're dealing with the synthetics. Well, let's say you do test positive, and you fire that person. You probably violated the ADA. In fact, you have violated the ADA because you have not engaged in the interactive process like you would with any other disability. And if somebody's not currently using, then they have some protection. So once there is a concern that the ADA may apply, the employer needs to be sure that human resources are engaged in the interactive process with the employee to explore whether any reasonable accommodations may be required. So you have an employee who tests positive, comes to you, or somebody comes to you and says, I'm undergoing treatment, I'm in rehab, I have protections under the ADA, whether they use those magic words or not. What do? You have a discussion. What do you need? Well, I've got to go to the methadone clinic, certain times in order to get my treatment that has been prescribed by my doctor. Well, that's the process that you need to engage in with your employee to accommodate that person. And there are cases out there that have determined that that's a reasonable accommodation. So what about family members? So you have a mom who is working with a son who is in treatment. And what you have to think about is, under the ADA, is there some protection there as well? And the courts haven't really addressed that issue too much, but it's likely that there will be protection. So it's one thing as owners of the company or human resource to understand these laws, but it's also another thing that your supervisors understand what the laws are and what the obligations are. And I would encourage you, if you are in human resources or own a company, to talk to your human resources people, make sure that your supervisors are educated on these issues so they can see the signs, so they understand how to deal with an employee who is coming back into the workforce after undergoing treatment. So medication-assisted treatment, the gold standard as Dr. Tobin described it. Again, there's no protection under the ADA or the FMLA for current use, but there's also no bright line as to what current use means. And there have been a lot of legal discussion about that. Does it apply to somebody who says, all right, yesterday I decided I am no longer going to use, I'm going to put myself into rehab. That may be too soon, that may not qualify for protection. But certainly we know that somebody who is getting medicine-assisted treatment certainly has protection under the ADA, and that does not qualify for current use. So it's a little bit of a gray area, and if you come into that situation, you have a questions, I would encourage you to call Megan, Bob, or me. We can kind of walk you through the facts and the circumstances and advise you accordingly. And again, the key point here is that there is ADA protection for an MAT program, even though the employee is using an opioid. Because if you remember, Suboxone, methadone is an opioid, but you're substituting a lower dose that is regulated by a physician in order to make that person feel normal so they're not going through the severe withdrawals that they were experiencing previously. And in those instances, an accommodation is absolutely required under the law. As a litigator, I have not seen a case yet where somebody, and I'm hopeful that is because we are trying to educate employers, where someone has been accused of, an employer has been accused of violating the ADA because they did not provide that accommodation. But I can assure you that they will be coming. And our goal is, as counselors, is to try to educate you as employers, not only as to what the legal rights are of employees, but also to do the right thing, to try to help somebody in need to come back to work and become a productive member of society. So that concludes our presentation on medicine and the law. You're now all experts. So we've come up with a couple hypotheticals to kind of run you through to try to really drive those points home. So we've got Jim. He's a longtime employee. He comes to you and confesses that he is addicted to opioids after he's missed a lot of work, and you're ready to fire him. You can kind of see that scenario playing out probably in your own workplace. He indicates, however, that he's done something. He's enrolled in a treatment program. You want to keep him on, but need to protect your company. So Jim asked for time off to undergo medication-assisted treatment, MAT, for opioid use disorder. Okay? Is the FMLA implicated here? Absolutely. What kind of documentation can you request from the employee in order to substantiate his claim? I'm going to turn this over to Bob as the expert here.
You're right. So the term is medical certification, and most employers who do FMLA have all the forms that you need for this, and the medical certification form goes to the doctor, to the treatment program, and so the answer was yes, FMLA is implicated. But the employer really needs to get his hands around that. You want to know what is the program? Is it truly a program? Is it legitimate? You want to know the dates when he's going to be in the program, and you also have the right to know how he's doing in the program. You can periodically check up in the program. Again, where it gets gray is what if there is a step back during the program? What if he leaves the program? That makes it complicated. But the other question is the ADA implicated here? Not really. He's not requesting accommodation, a reasonable accommodation. It might be when he comes back from treatment, if he says, I need to go periodically to receive some treatment and I need you to change my hours so I can do that, yes, arguably the ADA would be implicated. But just on this scenario, I don't think it's involved yet. And one of the great things that an employer has is a fitness for duty evaluation and also a last chance agreement that maybe, I know you do a lot of last chance agreements. You want to?
So a last chance agreement is a great practical way that an employer can protect themselves, but also try and motivate an employee who's struggling with addiction. And so I think this hypothetical is great because Jim is not cutting it as an employee because of his addiction. You have grounds to terminate his employment because of his issues with performance, missing work, etc. But you want to give him that chance. But you want to also make sure that he understands that this is a last chance, essentially. So what we call this is a last chance agreement or a substance abuse prevention agreement. And it's a written contract. It's usually, we do them for employers all the time. It's usually about a page long. And the employee is actually signing a contract with their employer where they're promising that they're going to stay in treatment, that they're not going to use, and that they're acknowledging that they're only continuing to be employed because of this promise. And that if they break this promise, that they should expect that their employment will be terminated. And whether their employment is actually terminated, whether you want to give them another chance, etc., you could decide that down the line, but it really does sort of set the expectation, and it helps give some teeth and some motivation to that employee and shows them that you're being loyal to them, which then in turn, hopefully you'll get loyalty back. You can also have them in that agreement agree to drug testing. You can have them agree to getting copies of drug testing results. You would probably have to get authorization from whoever is conducting the program for them or conducting the results. You probably have to fill out their separate authorization form because I've had this exact situation. That's what we had to do. It was a bit difficult because the treatment center didn't want to take the time or the resources to be affirmatively reaching out to the employer, and they put it back on the employee and the employer to do that. But I have had it in several situations where this has really been an effective tool.
This is just, I think, more for curiosity's sake than anything, but I'll just share with you that as a primary care provider, we don't know that a patient is engaged in a drug treatment program unless they tell us. There's actually privacy protections that are stronger than HIPAA protections, and so I don't know that the patient's using methadone. It does not show up on the, when you audit the controlled substance prescribing in our state. It doesn't show up on that list if it's not filled at a pharmacy, if it's dispensed. So when you as an employer work with your employees in drug treatment programs, if they're not getting that care from their primary care doctor, there's a very good chance you don't know either.
You can hang on to that?
Yeah, sure.
All right, so we got our next hypothetical, Maggie. Maggie's a prospective employee at ABC Corp. Tests positive for buprenorphine, which is a Suboxone, during her pre-employment testing. What does this mean, and what should you do? Any thoughts? What's that?
Active opioid ingredient is an opioid, as Monty said. It's a really unique one because actually, unlike something like morphine, for example, which is what we would call full opioid agonist, buprenorphine is a partial agonist. And what that means is it stimulates the receptors only partly. And so it does not have the same risk for overdose and dying that most other opioids do. And it also has a lower incidence of the euphoria and high that you might see with misusing other opioids as well. Now, any substance can be used in a way that's not safe, and buprenorphine can be used illicitly too. But it is, because of its pharmacologic properties, far safer and very, very unlikely to affect cognition and awareness and that kind of thing in somebody who's got some tolerance to the medication. It's also true that it usually will not show up in the urine unless it's tested for specifically. Many of these synthetic opioids, you have to actually request those alone, and then if you did a screen for opiates in the urine, and depending on what you're ordering, there's a good chance it won't show up. And from my perspective, we kind of have the opposite issue, where we're prescribing buprenorphine, and we're doing your drug testing to assess that they're actually taking it. And then I have to wonder, with my results, is it actually consistent with them using it? Because it's more complicated than it might seem. I'm looking for metabolites of it too, to make sure that they're not just taking their Suboxone film and dipping it in the urine, but they're actually putting it in their body. So there's some complexity with the testing.
I have one thing, just to elaborate a little bit more on what Monty said with regard to the ADA obligations. So if an employer finds out, either with a prospective employee or with a current employee, that they are being prescribed some type of medication, and they don't know what it is, and they are required to interact with this employee, they are not just required to ask the employee questions. Okay, they can, and I always recommend that the employer work with an attorney to come up with a series of questions for that employee to bring to their medical provider, questions that get to what the exact requirements of the position are, what types of activities they are required to perform, whether or not there are any side effects for the medication which could affect that employee's or prospective employee's ability to perform those functions in a safe manner. And those are the types of things that are questions that, again, help protect the employer and also protect the employee. If through that process it becomes clear that someone cannot safely perform their job because of the side effects of a medication, that's a very different situation than if just getting more information, it's clear that it's really not going to impact the person's ability to do their job. And the liability or potential exposure there is going to be very different depending on the answer to that question.
Another hypothetical, Carol. So your employee, Carol, tells you her son has an opioid abuse disorder and requests time off to take him to a methadone clinic. Do you have to accommodate the request?
Yes, yeah, this is straight FMLA, absolutely. No trick answers, or no trick questions here. But I'll throw a wrench. If I were to change that and say it was Carol, instead of her son, it was her father-in-law, who was retired and has some addiction issues that she needs to take to the clinic. Same answer? No. FMLA, that's the thing about FMLA, in parents, but not in-laws. So that's just a small distinction about the act.
It even applies to an adult child?
Yes, it could be your parent.
A 38-year-old son, and the parent is 60.
Absolutely.
Okay.
It does.
So it doesn't mean minors only.
That's correct.
But that also, if there would, they would have to have the paperwork for the FMLA.
Absolutely. They have to go through the whole certification process. That's correct. Yes, sir.
We could break FMLA down into, increments of hours, like she needed 2 hours here, 3 hours there.
Yes, and that's known as intermittent FMLA, where it's, it's a whole other process where I have to, it comes up intermittently, and I can take 2 hours here and 2 hours a week and go from there.
It's very common to have intermittent FMLA. It's also very complicated. It's a lot more complicated than someone who just goes out for a period of time and sort of is a hotbed for different issues. Also, it's very important that employers make sure that they are requiring their employees and the medical providers to provide documentation during those long periods and tracking things as well. I think the next hypothetical is me. This has to do with is it up there?
It is now.
Okay. This has to do with CDL licenses, and I mentioned before that CDL licenses are a license that is subject to different types of drug testing, and that's because of the recognition that obviously you don't want people under the influence of substances driving around on the roads. So Bob holds his CDL and he operates a truck for your company. He tests positive for fentanyl. Can you fire him? We didn't get into the nitty-gritty, but someone's nodding their head, yes. And the answer is yes. And the reason why is because fentanyl is a Schedule I drug. And under Department of Transportation regulations, same thing as marijuana, actually, because marijuana is still a Schedule I drug. You cannot have your CDL and and test positive for using a Schedule I drug and continue to keep your CDL license. The second scenario is a little bit different. Karen holds her CDL, and she also operates a truck for your company. She tests positive for hydrocodone. Can you fire her for the positive test?
No,
Why?
because it could be a physician prescribed hydrocodone, and it's not that she's using it illegally.
All right, again, we're gonna look at what schedule drug hydrocodone is, and I think it's, unless I read my article wrong, is it 1, 2? I think it's 2.
So actually fentanyl.
2.
So it gets a little complicated because even though it's used illicitly most of the time, it can also be prescribed.
Okay.
Yeah.
So if you had, so sorry about that, and I'm glad I have him to my left. If you have a Schedule II drug, and as the woman in the audience said, and you have a medical provider who has given the person a prescription for it, and they are familiar with the medical history of that person and can give a statement saying that given that medical history and given the proper use of that prescribed medication, that they can safely perform the functions of their job, you have to allow them to use it. Is that correct?
May I comment?
Yes.
It certainly gets, you have to personalize this. As a physician, you know, when I interpret these things from the medical point of view, it just depends on what dose, how long, what the context of their use is. Somebody who has chronic pain syndrome who uses a Duragesic fentanyl patch by prescription, which slowly releases the medication into their body, and has used it over time and has tolerance to the medication, maybe awake, alert, and able to perform their job without any problem at all. Somebody who uses fentanyl on the street, one dose and they may be dead. So it all depends upon the context of where it came from.
There's a question right here in front.
So you said CDL license, what if they're just operating a company vehicle as a driver with a regular license?
Would you repeat the question?
Can we use the microphone? So what if you have the same scenario, but it's not a CDL and you're operating a company vehicle and you just have the standard state license?
I mean, I would say that hopefully you would have a policy that says, again, this is going to get very tricky and very difficult, but you're going to have to weigh what's going on here. You're going to have to weigh what the requirements of the position are. You're going to have to get information about how the medication is being used and whether it's going to affect the ability. If it's something that could arguably affect their ability to be driving when properly using it, I would probably suggest that they not be allowed to use it, and or if the actual job requirements for that position are such that they have to be able to drive, it's going to be a difficult situation that maybe it's not going to be able to be something that you can accommodate from a business perspective, or maybe it is. So maybe you can transfer them to something else. Again, that's going to be very, very complicated.
So that was our last hypothetical. Just a summary of what can employees do. With anything, having clear policies and consistent enforcement is critical. Train and educate. Train and educate. Make sure your human resources people, your supervisors understand not just what the law is, but all the other things that we've talked about as to how to promote a good working environment and help your employees. Watch for impairment. Focus on behavior and work quality. Maintain good relationships with your employees. Engage in that interactive process that we've been talking about all night when an employee has a disability. Make sure you have an EAP. Take a look at it, make sure it's up to date. If you have any questions about it, Meg is an expert on it. And this is my mantra, right? Focus on helping and supporting your employees struggling with addiction instead of punishing them. Consider a last chance agreement, and don't be afraid to ask for help. So how can we help? Again, make sure your drug testing policy is up to date. Make sure you're complying with the applicable law. We can consult with you through the pre-employment process, train your management supervisors, guide you through the leave and reintegration process, guide you through the disciplinary process if necessary. And I would also offer this. I know I speak for Dr. Tobin and my colleagues at Pullman and Comley. We want to help combat the opioid crisis. We recognize that employers are a critical piece to solving this problem. If you have colleagues in other organizations and you'd like us to come talk to them, let us know. I think we'd be more than happy to take this show on the road talk to as many people as possible to help with that education process. Which leads us to the last part of the night, which is your questions.
You know, when we talk about health and we want to destigmatize this disease, and, you know, I think we should think of it as a disease. You know, what obligation and responsibility does the employer have for referring to helping agencies or those who may be dealing with this addiction? And secondly, is there a role for employers in helping to prevent addiction?
Well, I think, you know, is there a role for, I'll start with the second one, which is there a role for employers? Absolutely. I mean, that's why we're here. I mean, we want to educate employers so that not only you understand the medicine and the science behind it, but also what your obligations are as employers, and also to flip it from being a helpful employer to help your employees instead of being punitive and immediately going to that person's using. I don't care why. The drug test came positive, that person is out. You know, it's that education process that we think is so critical. The first part of your question is there an obligation, is there a reporting obligation? And I guess there are two parts to that. One is you certainly wanted to assist your employee who wants to go into a treatment program. But if the use is illegal, you know, is there a requirement that you go to the police and tell the police? I don't know. I'll refer to some of these smart people over here. But, I mean, you're certainly, if it's illegal use, you're certainly justified in terminating that employee. Whether you actually have to report it to the authorities.
If you're a federal contractor, you do. If you're a federal contractor, you do. If you're a private employer, I don't know. I mean, it's going to depend. You want to be consistent with your policies. I mean, I have employers that have a specific sentence or two in their policies that says employees should be aware that if anyone becomes aware of someone being under the influence of a substance or misuse of a substance at work, that they should expect that the authorities will be contacted. That they expect that coworkers will notify management and or call authorities. So again, that's a double-edged sword there. But I've seen all different approaches to it. I would just say that, you know, policies are a very important tool for employers. They're really the norm now. A lot of people are hesitant to have policies because they think that they tie you in to act a certain way. But actually, they do nothing of the sort. They help serve as a guide for supervisors, managers, in how to deal with issues in a thought-out way. They help provide a framework for consistency. And most importantly, they set expectations about what types of conduct and culture and behavior is acceptable, which especially the younger generation is now expecting. They want to know that. And if they're not seeing that in policies or there are no policies, they're saying, how was I supposed to know how I was supposed to act? Sort of tweak that, but that's one of my other points that I always want to address.
Staying on the line of reporting, what if it's a person who has a medical license?
I'm assuming you mean for medical marijuana? Is that what you're saying?
Oh, no, sorry. If you suspect someone of abuse and that person has a medical license, do you have a duty to report them?
Yeah, so I can't comment to the law the way these guys can. I can tell you that in my hospital and every hospital I've consulted with or worked with, there are very clear policies that there's an obligation to report concerns for impairment, whether it's a physician or any other healthcare provider. It does not make you immune from any of this. Please feel free to elaborate legally.
So are you required to report? If you,
Are you mandatory reporting?
Yeah.
I don't know.
So I'm not personally aware of a law that says that I need to report a colleague that's impaired. There are policies that are pretty universal, where if you don't report them, you're culpable, and it can lead to my own termination. So I really need to not just be a good citizen, but if I want to protect my own employment, I need to do that. But I'm not aware of it being a law. Again, these guys can talk to it better than I can.
thank you.
Sure.
Can you speak to the level of impairment for things like Suboxone and methadone, particularly in real sensitive safety jobs, dealing with dangerous substances, driving a truck, or even public safety?
Sure, do my best. So, in somebody who has opioid use disorder, who is prescribed medically supervised buprenorphine, Suboxone, or methadone, and is under the active care of a provider where that dose is monitored and adjusted as needed, they should be functioning normally. So, I mean, truly, what it does is stabilize them so that they can have functions that they never had, a drug use disorder to begin with. Somebody who is using intermittently any of these medications or using it as a substance of abuse, as opposed to a prescribed monitored treatment, very different. That person can have very severe impairment. But I think if you have proof that they're under the active care of a provider and they seem okay at work, that's the way they should be. They should be functioning normally. Again, the legal aspects of this for you, they would be able to speak to better than I can, but my expectation as a provider is that's the way they function. And in fact, it's one of the things that we look for. If there's any evidence that they are impaired, it means that we're not treating them correctly and we need to modify our therapy. I hope that answers your question.
Yeah, that does. One other point somebody was asking about an employer's obligation to report suspected use or whatever. I will tell you as an EMT, if somebody calls 911 on a medical emergency involving drugs and overdose and like that, the police will not make an arrest normally. Now, if somebody says, well, I threw all the stuff away or I don't have anything, they find they're lying, that's another story. But as a general rule, in order to encourage people to get help when they need it, the police are not making arrests in those kinds of situations.
You're absolutely right. And there's good Samaritan laws that are in place to protect the treatment of somebody who's overdosed, both protecting EMTs and first responders, but physicians and even just lay people who can get the rescue medication, naloxone, from a pharmacy, where, by the way, you don't actually need in our state to have a physician's prescription for it. A pharmacist who's gone through special training can prescribe themselves and dispense Narcan, naloxone, to somebody, even if it's not they themselves that are using the substance, but they're concerned about a family member. And so everybody, in my opinion, should have access to this. And these laws are in place for a very good reason, so that if somebody's overdosed, they get treatment. So I completely agree with what you said.
I know it's not relevant to the employer context, but I can tell you that there's a lot of work being done in the judicial branch to divert people to treatment programs who would otherwise end up in the system, which I think is a real positive way to combat the opioid crisis.
So I was going to ask, as a workplace issue, what have you seen so far, or what do you foresee coming in the workplace on either medical marijuana or recreational marijuana as it comes and has come in Massachusetts?
Medical marijuana. Okay, so in Connecticut right now, we just have legal medical marijuana. Okay, that means that if someone is a qualifying patient and they have a prescription for it and they are a card holder for medical marijuana, they are allowed to use it, but they are not, and this is a common issue that people don't necessarily understand. That does not mean that they are allowed to come to work under the influence of medical marijuana. Okay, they're not allowed to be impaired by medical marijuana at all. You can continue to have policies, and you should, that say that people cannot be under the influence of medical marijuana at work, and you should enforce that. You can have similar types of agreements if you find out that someone is a medical marijuana user, where you basically set forth that very clearly to them, and you say, I understand you're a medical marijuana patient. That's great, we support you in that, but we need you to understand that our policy here is that you're not to be under the influence at work, and setting forth the policy so that that's clear. In terms of recreational marijuana, obviously that is legalized in Massachusetts, and there has been a movement, obviously, kind of across the country for more and more legalization recreationally. But again, anybody, let's say someone goes to Massachusetts and then comes to work in Connecticut and they fail a drug test and they are not a medical marijuana user, you have grounds to terminate them or discipline them. Because just because it's recreational, with that failed drug test, technically you could terminate them. So that's if anyone has questions about medical marijuana, feel free to contact me offline. It's complicated, and obviously one of the biggest complicating factors is that it's difficult to know when someone's under the influence potentially, and a test isn't necessarily a good indicator of whether or not. And obviously if someone's a medical marijuana user, they're going to probably test positive in a lot of situations, and if you just acted quickly and terminated them without engaging in that process to determine whether or not they were a qualified medical marijuana patient, you would actually violate a part of the medical marijuana law in Connecticut, which has a explicit protection for employees and actually gives them a cause of action against you for essentially discriminating against them solely on the basis of their qualifying patient status.
Good evening. Thank you all. I'm detecting a distinct level of humanity, especially from Attorney Frank's comments, referable to workers in the workplace and how we should treat them. And I have to say, Dr. Tobin, that was probably the best presentation I've ever heard on the neurobiology of pain and opioids. There is a question here. We're also dealing, and I realize your task was treatment and legal accommodations, so we're not covering the whole landscape here. But there's an issue here of mental health and its associated problems with self-medication. There's a certain level of hopelessness and learned helplessness in the workplace, also in society in general. Escape from reality is getting easier because of the potency of not just the prescribed drugs and their adulterants, but also clearly the street drugs and their adulterants. I'm wondering if we could use the workplace employers to create a culture of not just treatment and accommodation, but also prevention. And I'm thinking of, upon hiring, would it be legally practical, and certainly it's medically available, to do an ACE test, trauma survey, and a happiness index on all prospective workers to get a clue as to what their backgrounds, coping mechanisms are, and actually use that employment opportunity to get them into the care system before it becomes a problem with productivity and the workplace, and then gets all of you engaged in trying to prevent us from getting sued.
Oh, there was a lot there. You want to go? Or?
I'll just take a piece of that. One of the aspects of your question was getting the employee into some form of employee assistance program or something that's going to benefit them early on, being proactive, if you will. And I think that the tension that's always there is when employers offer these programs and they advertise them and they encourage them, you can't force somebody. And that's where I can see some problems. In terms of testing, though, I don't know the answer about that. I'm not familiar with the happiness test, but I'm not sure if as long as you do it across the board in a non-discriminatory manner, I don't know if you'd have that many issues. What do you think, Megan?
I mean, again, I'm just looking at potential exposure here. I would be worried about what you would do with the results of those tests. So what decisions would be made as a result of those tests, and whether that could set you up for potential discrimination against someone for their mental health or not wanting to hire them because of that. I think that the idea is a good one, and I wholeheartedly agree with you that employers need to be more part of the solution when it comes to prevention, understanding how they need to support their employees. I'm just a little bit hesitant about this idea of doing any type of screening with regard to mental health at the beginning of the process, or really at any part of the process if it's not job related. Just to me could potentially create more problems than you would want to deal with, more problems than benefits. I do think when I think of prevention and I think of some other ideas, I mean, you could certainly have educational trainings on the medical, I found Dr. Tobin's presentation today to be fascinating about helping people understand the science behind it, what causes the addiction, those types of things. You could give education on the different types of community resources that are available. You could have pamphlets that you're giving out with regard to that. You could have sponsored activities with various different organizations that are involved in trying to combat this process, trying to encourage people, as Monty said, to use EAPs. So that would be encouraging them to go seek out counseling, providing free counseling for any type of addiction issues, or if someone would be predisposed to that. Those are all ways I think that I like that are a lot safer bet than doing some type of testing. You would be worried what you would find out, I think.
We have time for one more question. Anybody? Okay. So I just want to thank my friends who agreed to join me today. I think there's one takeaway that I leave you with is we often talk about stigma, and as employers, educating your colleagues in the workplace about the stigma associated with opioids would be tremendous, both in terms of the medicine behind it and how an employee is treated in the workplace if they are undergoing a medicine-assisted treatment program. It's interesting to me as a lawyer looking at employers, and if you have an employer who has acute pain and is taking oxycodone or Vicodin, there's no stigma around that. But if an employee comes back to work after going through a treatment program and is taking Suboxone or methadone, then you have that stigma, and you have that reluctance to try to accommodate that person. Notwithstanding that if you do accommodate that person, you probably have the most loyal employee in your workforce. That piece of it once, and that's why I think this program to me is so important. I jumped in when we asked, because if we can get employers educated to
get rid of that stigma, change the mindset away from stigma to how can I help, how can I accommodate that person, how can we create a situation where 1 + 1 = 3. Not only will you improve your workplace, but you will help society by combating the opioid crisis. So that's your job. Hopefully you'll take it up. If you have any questions, you can call any of us.
A couple last comments I just wanted to wrap up with. I think probably it's very clear to you that if you go to work, then you work with and alongside people who are either actively struggling or are in recovery from an addiction. That is how prevalent this disease is. And so for all of us as a society to have this education and understanding and humanity in our approach to it is so vitally important to us moving through this issue and coming out on the other side to a healthier, more connected world. So I think this was extraordinary. We talked about 3 things that we're doing as a group, the Rotarians and the Lions together. And we talked about home and we talked about workplace. And we just want to do a quick plug for our next event.
It's going to be Uprooting Addiction right here, May 14th at 6 o'clock. And there's flyers over there if you want to get them. And it'll explain more about it. It was an awesome, I saw the first, the viewing, I guess, at Warner Theater. And I don't know if we'll also be having any of the participants there as well, but it was definitely a wonderful program. So we hope to see you then as well. And if you would like to be part of our email system, let me know if you haven't already. Thank you so much for coming.
Thank you all.